Imagine a medical device just permanently fused inside the human body for 40 years.
Oh, wow.
Right.
Yeah.
And not because it was designed to be permanent, like, say, a pacemaker, but because a completely overlooked, intensely inflammatory skin condition just fundamentally altered the cellular landscape of the tissue around it.
It literally trapped the device inside.
Exactly. Welcome to today's deep dive. We are so thrilled to have you with us as we unpack this fascinating, highly urgent clinical puzzle.
It's a really complex one.
It is. Our mission today is to answer a deeply specific question. Can a patient with advanced vulvar architectural changes from a condition called lichen sclerosus safely utilize a mechanical support device, pessary, for pelvic organ prolapse, and can they do it without causing severe mucosal breakdown?
It is a question that really forces us to examine the human body at the intersection of biomechanics and cellular pathology. I mean, you simply cannot solve this puzzle by looking at just one isolated system.
No, you really can't. And to find the answer for you today, we have this incredible stack of sources in front of us.
We've got a lot of ground to cover.
We do. We are pulling directly from clinical guidelines on vaginal pessaries from the UK, dermatological case reports detailing the physical realities of lichen sclerosus, and some truly eye-opening insights from advanced pelvic floor physical therapy.
Right. And to even begin answering our core question, we need to isolate the two conditions first.
Makes sense. Where do we start?
Well, we have to understand the mechanical reality of pelvic organ prolapse, and then contrast that with the uniquely destructive biology of lichen sclerosus. Because if we don't understand the physical environment, we won't understand why combining their treatments creates such a high-stakes clinical clash.
Okay, let's unpack this. Before we try to figure out if these treatments can safely coexist for you or someone you might be caring for, we need to establish exactly how lichen sclerosus alters the landscape.
It alters it significantly.
Yeah, when I was looking through the dermatological sources, they described lichen sclerosus, or LS, as a chronic inflammatory autoimmune condition. But on a cellular level, what is the immune system actually doing to the tissue?
What's fascinating here is the precise nature of the immune system's attack. Because in a healthy body, your immune cells protect you from foreign invaders.
Right, that's their job.
Exactly. But in lichen sclerosus, specific white blood cells, primarily T cells, mistakenly identify the basal layer of the epidermis, so the deepest layer of the skin around the genitals, as a threat.
So they attack it.
Yeah, they release a massive flood of inflammatory cytokines, which are essentially chemical alarm signals.
And those alarm signals trigger a physical change on the surface. Because the sources mentioned the skin initially presenting as pale, thin, crinkled patches.
Yes, often in a figure eight or keyhole shape around the vulva and anus.
Right, so what's causing that specific look?
Well, that visual change is a direct result of the microscopic chaos underneath. The chronic inflammation forces the fibroblasts, the cells responsible for generating connective tissue, to basically go into overdrive.
Wow, okay, so they're overworking.
Exactly. They start overproducing an abnormal, highly rigid form of collagen. And if left untreated, this doesn't just sit on the surface, it drives permanent architectural changes.
Like the tissue's actually fusing together, right?
Yes, the tissues actually fuse. The labia minora can experience complete resorption, meaning they physically disappear. The clitoris can become buried under a thick layer of scar tissue.
Which sounds incredibly painful.
It is, and crucially for our discussion, this rigid collagen buildup causes severe narrowing of the entrance to the vagina. It's a condition known as introital stenosis.
So the opening itself shrinks and loses all of its elasticity. Now, on the other side of this puzzle, we have pelvic organ prolapse, or POP.
Which is a completely different mechanical issue.
Very different. Now, POP is incredibly common, affecting up to 50% of Paris women. The connective fascia and the pelvic floor muscles supporting the bladder, uterus, or rectum lose their structural integrity.
Right, causing those internal organs to physically drop down into the vaginal canal.
Yeah, and that structural failure creates a profound, debilitating sensation of heaviness and pressure for the patient.
It really does. So to treat it non-surgically, clinicians utilize a pessary.
Which is just a physical device, right?
Exactly. It's inserted into the vagina to literally prop those falling organs back up.
So putting this together, it sounds like a biomechanical nightmare.
That's a good way to put it.
I mean, if treating prolapse with a pessary is like carefully moving a large piece of furniture into a room for structural support, Lichen sclerosus is actively shrinking, stiffening, and locking the doorway to get in.
That is a highly accurate way to visualize the mechanics of it. You are trying to pass a supportive structure through a space that is rapidly losing its physical dimensions.
But I have to push back on this just a little bit based on a very specific detail in our dermatological sources.
Okay, what did you find?
They state unequivocally that lichen sclerosus never involves the vaginal mucosa itself. It is strictly an external skin condition affecting the vulva.
Yes, that's correct.
So if the active disease is entirely on the outside, why would a medical device that sits completely inside the vaginal canal be such a massive clinical problem?
It is an excellent distinction, and it highlights why treating this requires looking at the whole environment. You are totally correct that the T-cell attack of LS does not target the internal mucosal lining.
Right.
However, the entrance to the vagina is so heavily narrowed and scarred by the external LS that simply inserting and removing the pessary through that rigid opening causes immense physical trauma.
Oh, I see. Just getting it past the doorway is the issue.
Exactly. But beyond the entrance, we have to look at the systemic state of the typical patient.
You mean their age? Because the majority of these patients are postmenopausal women.
Precisely. And because they are postmenopausal, their bodies have experienced a massive drop in systemic estrogen.
And estrogen is important for that tissue.
It's vital. The vaginal mucosa is highly estrogen dependent. Without it, the internal walls suffer from vaginal atrophy. The squamous epithelium, the protective surface layer of the vagina, lacks the glycogen needed to maintain moisture and thickness.
So the internal walls become incredibly thin, dry, and fragile.
Yes. So you have a rigid, scarred entrance leading into a delicate, paper-thin interior.
That structural reality makes the introduction of a medical device incredibly risky, which makes me wonder about the nature of the device itself.
The material of the pessary.
Yeah. The sources note that modern pessaries, whether they are the standard ring shape or a space-occupying type like a Gellhorn for advanced prolapse, are made of medical-grade silicone.
Right, which is standard practice.
And it's chosen specifically because it is completely inert. It's hypoallergenic. So if the material is chemically inactive, why does the body react so violently to it? I mean, why doesn't the tissue just ignore it?
If we connect this to the bigger picture, the tissue breakdown has absolutely nothing to do with chemical allergies or material rejection.
It does.
No, not at all. It is purely an issue of mechanical physics. We are talking about the coefficient of friction and sustained mechanical pressure on compromised tissue.
Oh, wow. So just the physical rubbing against it.
Exactly. In a healthy vaginal environment, the walls have deep folds called rugae, which provide stretch, and they are well lubricated. They can accommodate the pressure of a pessary bearing the weight of a prolapsed bladder.
But the atrophic walls of our LS patient don't have that elasticity or moisture.
Exactly. They are flat and dry. When you place a rigid silicone device against that paper-thin tissue, the constant mechanical pressure actually compresses the tiny capillaries feeding the vaginal wall.
Which cuts off the blood supply.
Yes, it causes localized ischemia, meaning the tissue is starved of blood flow and oxygen. And without oxygen, those fragile surface cells die.
Oh, that makes sense. So it just breaks down.
Yeah. What starts as a microscopic erosion rapidly devolves into a deep local ulceration, an open necrotic sore on the vaginal wall.
And the moment you have an open sore in that environment, the risk of severe infection skyrockets.
Right.
But the case studies in our sources describe an even more alarming complication. They call it incarceration.
Yes, incarceration.
Where the pessary becomes permanently trapped in the vaginal tissue. I mentioned it at the very beginning, cases of devices neglected for 3 to 40 years.
Which is horrifying.
It is. But what really caught my attention wasn't the neglect. It was a phenomenon the researchers called rapid incarceration.
That is the most severe danger for a patient with LS and prolapse, because rapid incarceration doesn't take decades.
How fast does it happen?
It happens when those pressure-induced vaginal ulcers form or are already present when the pessary is inserted. The human body is remarkably efficient at trying to heal itself. The fibroblasts rush to the site of the ulcer to lay down new tissue and bridge the gap.
But the silicone device is sitting directly in the way of that healing process.
Yes, and instead of the tissue healing beneath the device, the granulation tissue simply grows directly around and through any pores, edges, or suction holes of the silicone.
So it's weaving itself into the device.
Precisely. The body physically incorporates the device into its own scar tissue matrix. The tissue fuses over it, permanently trapping it.
And getting it out at that point has to be a nightmare.
Oh, removing an incarcerated pessary at that point often requires complex surgical excision, causing massive trauma to an area that is already devastated.
That is terrifying. It's like the body's own biological healing response working against the mechanical solution.
Exactly right.
Here's where it gets really interesting, though. Because despite everything we've just uncovered, the shrinking doorway, the fragile ischemic walls, the terrifying risk of the tissue fusing to the silicone, the medical consensus in our sources to our core focus quotient is actually,
Yes.
it is. A patient with advanced vulvar architectural changes from LS can safely use a pessary for their prolapse,
It is a definitive yes, but it comes with a massive non-negotiable caveat.
which is the preparation, right?
Exactly. It requires a highly synchronized, multi-step preparatory phase. You cannot simply force a structural solution into a biologically hostile environment. You have to actively remodel the cellular landscape first.
Right. You can't just forcefully stretch that fibrotic, scarred tissue. So how do clinicians safely alter this environment to accept the device?
It demands a multidisciplinary approach. Step 1 is achieving absolute dermatological control over the lichen sclerosus. You have to stop the autoimmune attack at the cellular level.
And how do they do that?
This requires the use of ultra-potent topical corticosteroids, like clobetasol.
How do those steroids actually work? I mean, they aren't just numbing the itch, right?
Oh, far from it. The corticosteroid molecules physically enter the nucleus of the immune cells in the skin and suppress the specific genes that produce those inflammatory cytokines we discussed earlier.
Wow, so they shut down the alarm system.
Yes, they effectively cut the communication lines of the hyperactive T cells, ordering them to stand down. This halts the active disease process, stops the intense itching, and critically prevents the fibroblasts from producing any more of that rigid scar tissue.
Okay, so the steroids stop the autoimmune attack on the outside, but they don't do anything to reverse the thinning of the internal vaginal walls caused by the systemic lack of estrogen, do they?
No, they don't.
You still have a paper-thin interior.
Which leads us directly to the second mandatory step, which is hormonal preparation. The clinical guidelines clearly state that for patients with vaginal atrophy, localized intravaginal estrogen, usually a cream or a sustained release ring, is essential.
And this is different from taking estrogen pills, right?
Very different. This is not systemic hormone replacement therapy circulating through the whole body. It is targeted directly at the local pelvic tissue.
And what is that estrogen doing on a cellular level to prepare the walls for the silicone?
The estrogen molecules bind to intracellular receptors in the vaginal mucosa. This triggers a biological cascade. It stimulates rapid cell division, physically rebuilding and thickening the layers of the squamous epithelium.
So it's building up the armor.
Exactly. It prompts the production of collagen and elastin, restoring stretch. It increases local blood flow, and it forces the cells to produce glycogen.
Which helps with the natural flora.
Yes, the glycogen feeds the healthy lactobacilli bacteria in the vagina, dropping the pH and restoring natural moisture.
That's incredible.
It physically transforms the tissue from thin and fragile to thick, resilient, and lubricated, ensuring any existing micro-ulcers are completely healed before the pessary is ever introduced.
It's an incredible biological reconstruction. You suppress the immune fire on the outside with steroids, and you rebuild the structural walls on the inside with estrogen.
That's the 1-2 punch.
But there's a third pillar to this preparation phase found in our physical therapy sources that completely shifted my perspective.
Ah, yes. Pelvic floor physical therapy is frequently the missing link in complex pelvic health cases.
Why is that?
Well, you have to consider the muscular response to chronic pain. When a patient has been experiencing severe chronic vulvar pain from the cracking and tearing of lichen sclerosus, their pelvic floor muscles don't just sit there.
They react. It's a reflex, right? They guard against the pain.
Exactly. It is a subconscious protective guarding mechanism. The pelvic floor acts like a hammock of muscle supporting the organs. In response to the persistent external pain, those muscles become chronically tight, hypertonic, and locked in a state of continuous spasm.
So if you try to put a device in there,
If a clinician attempts to insert a pessary into a pelvic floor that is rigidly guarding, it will be excruciatingly painful for the patient, and the device will immediately be forced out of position.
and what blew my mind in the physical therapy guidelines is what they explicitly tell patients not to do. When we hear pelvic floor, the immediate cultural association is, oh, I need to do Kegels to strengthen it.
Right, everyone thinks of Kegels.
But for a patient with LS and pelvic pain, the guidelines state the goal is absolutely not to do Kegels.
Because the muscles are already working overtime. They are exhausted, tight, and starved of oxygen due to that constant tension. Doing Kegels would be like asking someone with a severely cramped calf muscle to start doing calf raises.
That makes perfect biological sense. So instead of strengthening, the physical therapist uses specialized manual therapy. How does manually pressing on the tissue actually change the muscle function?
The therapist uses targeted manual pressure to physically stretch the sarcomeres. Those are the fundamental contracting units within the muscle fibers.
Okay, so they're mechanically releasing it.
Yes. By applying sustained, gentle pressure to trigger points, they encourage the muscle fibers to release their contraction. This mechanical lengthening restores capillary blood flow to the ischemic tissue, bringing in oxygen and clearing out metabolic waste products that cause pain.
The sources also mention the use of progressive vaginal dilators.
Yes. Dilators are smooth, medical-grade silicone or plastic cylinders of gradually increasing sizes. The therapist uses them to apply gentle, controlled mechanical stretch to the narrowed, scarred vaginal opening, the introital stenosis we discussed.
So they're slowly stretching the doorway back open.
Right. This process, known as mechanotransduction, slowly signals the fibrotic tissue to reorganize and lengthen. And while it does that, it simultaneously desensitizes the nervous system, retraining the muscles to accept penetration without immediately going into a protective spasm.
It is a massive, highly coordinated rehabilitation effort. You are reshaping the doorway with manual therapy, reinforcing the interior walls with estrogen, and shutting down the faulty immune alarm system with steroids, all before you even attempt to bring the supportive furniture into the room.
And only after all three of those criteria are met, inflammation controlled, tissue plumped, and muscles relaxed, can a skilled clinician carefully measure and fit the pessary.
It sounds like a lot of trial and error.
It requires a meticulous trial and error process to find the exact shape and size that supports the prolapsed organs while distributing the mechanical pressure evenly across the newly fortified tissues.
So what does this all mean for the patient moving forward? Once they've gone through this intense prep phase and the pessary is successfully fitted and supporting the prolapse, are they done? Can they just go back to living their life?
This raises an important question, and frankly, it's where the stakes are the absolute highest in this entire clinical picture.
I have a feeling the answer is no.
The short answer is no. The vaginal environment of an LS patient remains highly volatile. The guidelines are entirely unequivocal. The inability to comply with a strict, long-term maintenance protocol is an absolute contraindication for a pessary.
Wow, absolute contraindication.
Yes, if you or your caregiver cannot commit to the follow-up, a responsible clinician will not prescribe the device.
Because the risk of slipping back into that cycle of ulceration and rapid incarceration is just too high.
Exactly. For a patient who is physically and cognitively able to self-manage, they are instructed to remove the pessary at minimum every single week.
Okay, every week.
They clean it with simple soapy water, and crucially, they leave it out overnight. This relieves the mechanical pressure and allows the capillaries in the vaginal wall to fully perfuse the tissue with oxygen, giving the mucosa a necessary rest.
But what if they can't? Like if a patient has mobility issues, severe arthritis, or cognitive limitations and cannot manage the removal themselves, the medical team has to take over that responsibility.
Right, the guidelines state they must be seen in the clinic every 3 months initially and then every 6 months. The clinician removes it, cleans it, and meticulously inspects the vaginal walls.
Looking for those early erosions.
Yes. If they see even a hint of friction or early erosion, the pessary is left out entirely until the local estrogen can stimulate cellular repair.
But there is a much more critical, potentially life-saving reason for this relentless professional follow-up, isn't there?
Yes. And it is a biological reality that both the patient and the provider must remain hyper-vigilant about. Lichen sclerosus is not just an uncomfortable skin condition.
Right.
If left untreated or if it's poorly managed over time, it carries an estimated 5% risk of progressing to a specific type of skin cancer known as vulvar squamous cell carcinoma.
5%. 1 in 20 patients. That is a deeply significant risk factor. How does an autoimmune condition turn into cancer?
It comes down to cellular turnover. The chronic, unyielding inflammation of LS forces the skin cells to constantly die and rapidly regenerate. The condition creates a precursor state called differentiated vulvar intraepithelial neoplasia.
Let's break that term down for a second.
Essentially, intraepithelial neoplasia means there is abnormal mutated cellular growth happening entirely within the surface layer of the skin, the epithelium.
Okay.
Every single time a cell is forced to divide rapidly to repair inflammatory damage, there's a tiny chance for a DNA copying error. When that rapid, desperate cellular repair goes on for years because the LS isn't controlled, those DNA mutations accumulate.
Oh, I see.
Eventually, those abnormal cells break through the basement membrane and become invasive squamous cell carcinoma.
So when the clinician is performing that 3-month or 6-month pessary removal and cleaning, they aren't just looking for friction sores from the silicone. They are conducting a vital cancer screening.
Precisely. They are palpating the tissue, looking for new, hardened lumps, persistent sores that refuse to heal despite estrogen, or highly thickened raised plaques that signal malignant cellular changes.
Because the pessary is a space-occupying device.
Yes, regular removal is the only way to get a clear, unobstructed view of the entire vaginal and vulvar architecture. If you skip those exams, a tumor could easily develop silently, completely hidden behind the silicone structure.
So what does this all mean? I think the best way to conceptualize this for anyone facing this dual diagnosis is to completely throw out the idea of a standard medical implant.
Absolutely.
Using a pessary with lichen sclerosus is not a set-it-and-forget-it intervention like getting an artificial titanium hip or knee replacement.
Not in the slightest. The tissue environment is far too dynamic.
It's much more akin to wearing a highly specialized dental retainer, but placing it into a jawbone that is constantly shifting, inflamed, and prone to disease.
That's a great analogy.
Right. It absolutely requires daily hygiene, constant chemical environmental monitoring with their topical steroids and localized hormones, and regular professional adjustments to ensure the device is genuinely supporting the structure rather than silently destroying the delicate tissue it rests against.
It demands total, ongoing synergy between the patient, their caregivers, and a diverse medical team.
Let's bring this all together for you.
Why?
We started this deep dive with a highly specific clinical puzzle. Can you safely use a mechanical support pessary for pelvic organ prolapse when your tissue architecture is severely compromised and scarred by lichen sclerosus?
Right.
And we found that while it is an incredibly complex biomechanical challenge, fraught with severe risks like ulceration, tissue incarceration, and hidden malignancies, it is entirely possible.
But it requires a meticulously choreographed biological dance.
A flawless dance. You must deploy potent topical steroids to enter the immune cells and shut down the autoimmune alarm bells. You must utilize targeted intravaginal estrogen to stimulate cellular division and rebuild the structural integrity of the mucosal walls.
And don't forget the physical therapy.
Exactly. You must engage in specialized manual pelvic floor physical therapy to stretch the muscle fibers, restore blood flow, and stop the reflexive guarding. And finally, you must commit to incredibly vigilant, lifelong clinical follow-up to prevent the body from fusing to the device and to monitor the epithelial cells for that 5% risk of cancer.
As we conclude our analysis of these sources, I want to leave you with a final thought to mull over.
I'd love to hear it.
Consider how this highly specific medical puzzle completely redefines how we view the body systems. We often treat dermatology, gynecology, and musculoskeletal physical therapy as entirely separate disciplines.
Oh, that's true. Like, they're totally different silos.
Exactly. Yet, in the case of a patient with LS and prolapse, you cannot mechanically support a failing internal organ without first healing the skin and retraining the muscles. It shows us that the human body isn't a collection of isolated parts.
It's all connected.
It is one continuous, profoundly interconnected ecosystem where the health of the surface directly dictates the survival of the structure beneath.
That is a phenomenal perspective. Thank you so much for joining us on this deep dive. We hope it helped clear the waters for you. Until next time.